Okay, Bill, whenever you're ready.
Well, it's great to be back with you guys. This is certainly not as quaint as it was when we were all together this summer, but it's good to be back. And the second thing is I've never done this by distance technology. This has usually been more of an interactive discussion, question and answer, and trying to go where the audience wants to go. And so I'm going to try to do some of that periodically during the call and see how well we can make that work. I've got a series of slides. We don't have to make it through all the slides. A lot of the slides relate to a lot of data because we know we have epidemiologists in the audience, but the focus is going to be more on the process, the challenges, the barriers, the opportunities, than specifically on the results themselves. But I'll give you enough of the results so that you can get a sense of what we did and the process and in pieces, if that makes sense. And now we're talking about translation sciences, but when it comes down to practice at a state and local level, I think of it more of it as actually data use. How do we use data to help guide and direct decision making? And so we'll walk through those pieces. I think the key gets to be is to immediately think about how epidemiology in some ways needs to be oriented differently in our minds and our thought processes because of how we come out of schools and how we teach people about epidemiology. The classic definition of epidemiology is a study of the distribution and determinants of health-related states or events in specific populations and the application of this study to the control of human problems. But it really focuses a lot much more on the study of distribution and determinants than it does necessarily on the control of health problems. Due to some work that Arden Handler had done back with UIC back in the early 90s, along with several other people, Deb Rosenberg, and I know I can't even begin to name all the people, we actually came up with the first sort of MCH definition of epidemiology in terms of published nature, and then we've refined that. The new refined definition came out of the Coalition for Excellence in MCH Epidemiology. This represents like 16 national organizations, and they've been tasked with recognizing and giving out the epidemiology awards in MCH. That includes advancing knowledge, effective practice, leadership, teaching, and obviously, as you can imagine, when you're going to start recognizing excellence, you need to define what you're recognizing excellence in. And so they took it as and redefined it, starting with what Arden and her group had done, calling it the systematic collection, analysis, and interpretation of population-based and program-specific health and related data in order to assess the distribution and determinants of health status and the needs of the MCA maternal and child population for the purposes of planning, implementing, and assessing effective science-based strategies and promoting health policy and development. So clearly you can read in there the distribution determinants, but we talked about the systematic process, we talked about the data pieces, but also we really started to talk about what the real purpose is: planning, implementing, assessing effective science-based strategies and promoting policy development. And frequently at an academic center or a national HHS location, they may do that much more from the purest science perspective and publication and eventually affecting practice. However, when you're at a state and local level, this gets to be all intertwined, and we're going to spend a little bit of time talking about that. Again, it is about this purpose of planning, implementing, assessing effective and science-based strategies and promoting public policy development. So let's talk a little bit about effective MCH-EPI practice. after some of the initial work that Arden had done on MCH epidemiology and evaluating CDC as a signing program, almost 8 to 10 years later, Deb Rosenberg was funded as a lead to talk about. Well, I moved that piece, so that's going to come later. I'm sorry, my slides are out of order. So let's talk about this idea, and I mentioned this concept to you all when we were together. To create the change that we really want to have in public health, we need to think about three things, to keep it simple. Julius Richmond, former Surgeon General, and Milt Kulchuk came up with it. One, we need to have a clear knowledge base. We need to have a social strategy, and we need to have political will. That knowledge base means we need to have an understanding of the science and understanding of the context and the data that we have in the situation. By social strategy, we need an intervention that's effective, whether it's a policy or a program or what we're trying to do. And we really need to have the political will to have it happen. And if you do not have all three, you will not and cannot succeed. We frequently have political will, but there is no data to support it, no real effective strategy, and it doesn't work. And some of the initial work on abstinence really drove that home. Newer stuff is coming out looking better, but that original work was more politically will-driven, not a good knowledge base, not a good social strategy. A lot of it didn't work. Frequently on the epidemiologist side, we collect the data and the science, and we say, looky here, here's the problem, you need to do something about it. But we don't often have an effective social strategy. And so you really can't do something without that effective social strategy. But frequently in public health, what we're stumbling into now, and I don't know what your experience is, but mine was up to about December was, we had a knowledge base of science and data, and we had effective social strategy, but we didn't have the political will to make it happen. And so you need to think about this, and to me, this has become sort of my immediate framework when I start thinking about epi practice. And to that, to me, that from some work we did in City Match, leads us to think of what we call the data use triangle. And in the middle of that is translation. By this, what we're saying is it's going to take all three pieces. So it's going to take three different types of pieces to do this. We need people who are skilled in data analysis. We need people who are skilled in planning and programs. And we need people who are skilled in politics and policy. And we need to be able to work together to effectively do translation. And my favorite scenario, and it's amazing over my 28 years how the scenario hasn't changed. You talk to some of the data people and they go, oh, those program people. They want this data. They don't really know what they want. They don't know exactly why they want it. And when you finally get them what they want, they've changed their mind what they want, and they want something else. And then they go off and they do crazy things with the data that don't make any sense. And then on the planning and program side, they go, oh, those data people. You ask for data, you tell them what you need. They can't necessarily give it to you, but you finally figure out something to give it to you, and then they tell you how long it's going to take to get it to you. And then when they give it to you, they tell you, well, you got to be careful. This is not really reliable, and the data is not stable. So you got to be all these qualifications that have got to be there. And then you go over to the political leaders, and they go, don't confuse me that. Just give me the data I need to support the current position of the governor's office. And so you get into what I call that separatist approach. And then you wonder why we can't necessarily pull it all together. And then the person says, well, it's them. They need to come over to me, or I need to come over to them. And the key gets to be is you got to do it together. And that starts from what are the questions we need to be answering, what are the data we really need, what do the results really mean, and what do we do about it? And the idea is all three have to work together and own it, or you really can't get what I call effective data translation. So in my practice in MCH Epi, I would almost either try to start with this team, or I would try to have it migrate to this team and approach, so that we would have all the aspects there. So, and we'll talk a little bit more about that, but this idea, and in this triangle, we got to remember that our whole team is doing this in the context of a community, and that we are not insular in and of ourselves, that we may need to broaden our framework of what we're trying to do and how we're trying to think. And community input along the way can be very helpful. Going back over a decade or so, there was a survey done by the National Association of Evaluators. And they were talking about what was, in their survey, what was the number one problem related to program evaluation. And the number one problem that they identified, it's been about 12, 13 years now, was people didn't actually use the results. Okay? The number one problem wasn't methodology, cost, money. It was you got all the way to the end and people weren't using the results. And they had a long list of what they were, but I'm going to summarize some of what those lists were. First, the problem was the stakeholders were not engaged. If the stakeholders and the people who are going to use the data are not engaged in the question, in the methods, in the results, the interpretation, implementation, when you come back with them later with the data, you're going to wonder why they don't want it. Is it because it may not relate to what they need? They didn't get engaged in the process. Moreover, what may be discovered may not be what they were looking for, and all of a sudden you've got that dynamic. Frequently, what we find was the evaluations were answering the wrong questions. Evaluators have certain key tools they put in their pocket that they use all the time, and so they're used to those tools, and so frequently if people are not engaged, they will go off and do an evaluation that they can do. Now, it may answer the wrong questions that need to be answered in terms of moving and improving the program, but they can do those, and that's what they do. In fact, I love it when people go out and get an evaluator to do a specific type of evaluation because they've almost lost it because they may not be answering the right questions. And it's not like it's always a cookie cutter. Because usually, as a state and local public health agency, you can't afford to purchase the whole evaluation package. The second one is evaluators lose credibility. Essentially, by using different language, different approaches, and the dynamics and not engaging together, in the end, by the time the evaluation comes out, the people supposed to use results don't believe in the evaluator, so it doesn't matter what results you gave them, they're not going to do it because they can't believe it. It is important to know, the fourth one is that frequently they don't even read the results, let alone understand them. And part of it gets to be is if you haven't been engaging them and you now give them this whole huge report, you now have a huge educational problem on your hand, and getting them to learn and understand and see what it is that you say that was covered. And again, if they weren't involved along the way, all of it is new, it doesn't feel right, doesn't sound right, and so there's an apathy that's there. The fourth is they get it and they don't like the results. And so if it doesn't support what they want, they're just not going to use them. And the last one, which I added in, that they didn't add it in, is frequently when you're doing something, people are not wanting change. So if you're bringing something up that's creating change or issues, they just don't want to hear about it. Why don't we open it up now? Anybody else have reasons why people don't use evaluations and results? No one has any other reasons why. Okay. We'll continue on. Now, I don't know about your training, but in my training, again, we go back to that definition. We did a lot of time training about analytic approaches and stuff to understanding distributions and understanding determinants, and that forms descriptive epidemiology and analytic epidemiology. And it was really all these tools that would help us do that and look at sort of the causation pieces and the surveillance pieces that's going on. And a lot of that training focused on either generating new knowledge that could be gained from that experience or confirming knowledge that we already have and sort of estimating what the situation is. So in some ways, like an evaluator, we're sort of trained with these tools that we get that we're used to always doing. So if we're going to study a problem, the first thing we think of, we need to know what the magnitude is, and we're going to study all the different risk factors. And then, you see this interesting pattern here. Now I want to narrow in and do this analytic study to see what's going on with this pattern. And I'm out here to create new knowledge and to confirm what's already going on. And then I go off and I present it to the program and the policy people, and they go, okay, that's interesting. So that we're really coming at it from the potential that we're not answering the right questions, or we're not answering in a way that they can see that it's answering the questions that they have. And I must tell you, I learned a lot of this the hard way, because I'd go off and do really neat epi things, and I could go off to my epi meetings and show this really neat epi work, and everybody was so excited to see it. But it did not necessarily mean that I went back home and showed it to the program and the policy people, and they would say, thinking, that's really nice, that's really interesting, but then if I waited to see if there was change, nobody did anything with it. Okay? In the South, we're all real polite, and we tell you that we really liked what you did, and we tell you did a really good job, and I might even mention to the health director the nice job that you did, but the day-to-day practice of that division or that bureau or that group didn't really change. And from my perspective, that meant as an epidemiologist, I was not succeeding. So then I would hear from people like Bill Fahy, who's a former CDC director. He was president of APHA. He went over and started a lot of the health work for the Gates Foundation and was instrumental in setting up a lot of that foundation work. And what he captured, what we did, and he's really got a claim for helping eradicate smallpox. And his whole concept was, at CDC, public health, we do what's called consequential epidemiology. In other words, we do epidemiology that makes a difference. What we are supposed to do is do something that leads to change that's necessary to address the public health problem. Now, Bill Fahy said this probably near and around the beginning of my career in the 1980s. And lo and behold, we now have Tom Frieden, our new CDC director. And what he does is he calls it intervention epidemiology. The whole idea is that our epidemiology ought to be geared for us to do an intervention, to do action, to do something to change public health. And so the key here gets to be is reorienting our epi thoughts from some of that training we have to trying to talk about it as a tool. We spent a good bit of time together talking about planning. And I mentioned it then, and I want to go back to it. To be effective in public health, to do what we need to do in epidemiology, we need to think of the planning cycle and where our data and where our expertise and knowledge contributes to the decision-making process. Now, this will go back, as we talked about. Sometimes you'll be in a place, in an agency, a division, bureau, or a work area where people are not planning. And if there's no planning process, it gets to be very, very hard to use our data. Now, if I can't find higher-level planning processes, frequently what I will do is go to the program areas then, because I know there's usually somebody who's effective in a program, and if they're being effective in a program, I promise you that means they're planning. And so frequently a lot of my efforts then would be to link up with the people within my area who are creating change, because I used to have a boss who tried to get me to work with the people who weren't creating change, and after years of trying to get people who don't do change to create change, it is a resource-intensive process. What I found is that if I go after the people who are creating change, who are doing the planning, and I can work with them to show what epi and data can do, then those early adapters are the people who can get the next group of people to come along and do those changes, because they'll want to do what those others are doing because they're succeeding. So they're sort of the imitators. So you have the early adapters, you have those sort of imitators who want to follow along, and then you have that sort of group who may not change at all. And my experience over time is I'm an opportunist. I've been doing these things for long enough time that I know eventually something will come up. A crisis, a change in personnel, a major grant, but something will happen in that bottom third of the group, and that's when then I can step in and help work with the data to create further change, because there's something that's going to make change more important. So literally, when we start thinking about pulling out our tools and where can we contribute and how can we lead to translation, we need to think about this sort of process. Now, obviously, the key gets to be is we need to be choosing carefully what that issue is that we're trying to address and change. And we talked about some of that from a needs assessment perspective and a prioritization perspective. So I'm not going to go back over some of that we covered together in the summer, where we really spent time on that. And we did some problem analysis, which talks about some of these different phases. So we're not going to go back over those pieces, but we've got to go back to this piece. So when we think about where we as epidemiologists and data people can contribute, one of these other boxes should be red, there are actually 4 areas where we contribute on the planning map. In assessment, in strategy development, I'm sorry, that should be red, in monitoring, which monitors implementation, and in evaluation. Under assessment, we should be, 1, prioritizing, and then talking about and describing what that problem is. And as an epidemiologist, we need to either be doing that to create awareness of a new problem that people are not addressing so that we can start an overall planning process, or it needs to be leading to strategy development. But it's either got to go up or it's got to go down for that assessment and that data activity to work. So that we need to be thinking ahead, okay, if I go ahead and I have this new area in public health we're trying to work on, am I doing this for assessment, for strategy development? Am I doing it for awareness? And then if I'm doing it for awareness, who is my audience? Who am I trying to make aware? How will the analysis I'm doing help do that? What does the report and process need to look like, so that when I start to think about the analysis that I'm doing, I have that audience in mind, I have that purpose in mind. I am looking ahead at what the results are to see what I need to do. I really like what Paul Blake used to say. He was one of the people for years who was in charge of the gastrointestinal disease units at CDC. He did all the foodborne outbreaks nationwide. And it was really, when he told me in EIS, it didn't make much sense, but it makes perfect sense now. He said, if I didn't know what I was looking for when I went in an investigation, I never found it. In other words, if he didn't know what the results were of what he was trying to look at by the end of his investigation was not going to be useful. It was not going to lead to consequential epidemiology. It was not going to identify the foodborne outbreak and create the preventive efforts we need. And when we look at MCH, even though it's not infectious disease, we need to be looking ahead. What is it that we're trying to see? What is it that we're trying to do to make sure that what we're doing will actually lead to those results? The same with strategy development. We're going to be helping the group review to make sure that it's evidence-based and data-driven, fits within the context of the community. We're going to be helping develop those monitoring pieces on those things that are really worth reporting to make sure that implementation is taking place, that we're having those initial outputs that need to take place or those activities, and that we're literally having those first initial outcomes that need to take place. And the same with evaluation. And if you remember back to what we talked about in the summer, this whole planning process is about a team. It's not about an individual. It's not about the data people going off and doing their piece and the program people doing their piece and the policy people doing their piece. It's about us sort of working in these pieces together at each of our steps. So if you're trying to design something that's going to really lead to data translation and effectiveness, you've got to think of the team, the players, the step where you're at, and the results that you're really trying to get at the end and how you're trying to go together towards that change. And everybody needs to sort of agree with what the process is on how to make those key decisions. It's not about just going back to our offices and running some really cool analyses. Let's talk a little bit about some of the common mistakes that I see. I've been supervising epidemiologists and fellows and senior epidemiologists in maternal child health for quite a few years, and I continue to see some of these problems. There are others, but these are some of the more common. The first one that I like is before we break, we're going to let the statistics speak for themselves. My most favorite thing that I see is that as epidemiologists, we think we've done this cool result, we've done this cool graph, we've done this cool report, and the data speaks for what needs to happen. Oh, we'll write our recommendations out and all those pieces, but somehow we think that showing them the data is going to make a difference. And let me give you a classic example. I don't know how many of you have done perinatal periods of risk, but it's an approach to look at infant mortality. It's a very neat, nifty approach. It helps you look at risk periods of when things happen that help lead to prevention strategies. It looks for excess mortality to show where you need to focus your efforts. It's a really cool community tool that uses epi and data. But it's often interesting to watch epidemiologists to go back into their office and run the perinatal periods of risk analysis, print all these maps, all these grids, all these reports, and give it out to people and say, see, now you can do something. Here's where your infant mortality problem is. And when you do that, my experience has been as a data person then is sort of talking to that program person again and again about what it is that they found. And there's no engagement by the program and the policy people because it's sort of data and it's hitting them at an unusual time. They're not sure how they're going to use it or embrace it. It wasn't necessarily what they asked for. It's not sure what they mean. And when we launched this initiative with City Match and we pulled cities together, the first thing we required them to do was to have a group together committed to working on fetal and infant mortality, and that you couldn't do the analysis until you started to have that group together. I will always remember Nashville. They were mad at us. We made them wait a whole year to get their community together before they did their risk analysis. They said, oh, we're going to do a risk analysis. And I said, what you're going to do is you do that first, you're going to go beat after people with data, assuming that if I hit them with the data, they're somehow going to do something. And I can tell you that does not work. So the key got to be they waited a year, they got their group together, and they took off flying very quickly. So the key gets to be is the only thing data speaks to is to you and I as epidemiologists. Program policy people generally and political leaders don't necessarily have data speak to them. In fact, a recent report that compared staffers to state and federal senators and legislators were the staffers want stories. It's only the politicians who are interested in actually seeing the data. So their staffers didn't necessarily want what they want. So this is one of the first problems, that somehow we think the data speaks and we can create energy, political will, and something happens just by showing them the data. The second thing is many of us who go off into epidemiologists are numbers people, and frequently numbers people are not people. And many of my epidemiologist colleagues sort of want to go off to their office and do the analysis and not be confused. I mean, I actually had someone stand up at a national birth defects meeting and say, those program people just need to leave me alone so I can run my surveillance reports. As if running the surveillance reports was going to solve the problem. So the other thing is they'll try to get somebody else to do it, and not recognizing that it's got to be a team. We've got to do it together collectively. The other thing is to think that we can do it outside of some sort of planning process. I mean, people will sit down with me and ask for advice, saying, Bill, you know, I've done this really neat, nifty product, and here's this report, and here's this piece, and I've got all these results, and I can't figure out how to get the program and policy people to listen to me and see what's going on. And then I'll start asking, well, who helped you with the question? Who were you with? Where were you going? And so it's all about, I now have the data, and so they've done it devoid. The fourth thing, which is really hard and really painful, is it really takes time to use results. By that, you may do a report, you may do a piece, and you may look for action immediately, but frequently it takes time to recognize it. It takes time for them to absorb it, to think about it, but more about it, it's sort of that change state of mind. It's going to take them a while so they actively start creating it and using it. I think I even threw out an example to you at our training when I talked about how we found out that Florida had some of the lowest contraceptive use rates in the country. And nobody knew it. And then once I told them, they said that was interesting. But then when I started to include it in all of my speeches, when I started to include it in every group that I went to, when I brought it up at every meeting, and I could talk about how Mississippi and Tennessee and how Georgia were all doing substantially better than Florida in this issue, and then I could talk about the consequences of unintended pregnancy, it started to be people in the audience would say, well, Bill, are you going to tell us about contraceptive use problems now? They sort of predicted what it was. But all of a sudden, family planning that used to be a stepsister program beaten up by politics that nobody was interested in, all of a sudden started to be a priority. And in fact, when they started to go after our family planning dollars for the state and cut two-thirds of it away, we were able to use our data that we had built up with a case to go back to legislators indirectly, because the governor's office wouldn't support it, to talk about how Florida is so far behind, how can you be doing this? Jocelyn Elder said, for people to hear you, you need to tell them 20 times. So if you've done this needs assessment, you've identified this priority issue, you've described where the problem is, you've done this evaluation and you're showing something's not working, you're going to have to stay in the meeting and keep reminding them that this is an issue. You're going to have to look for the opportunity. And you say, well, this is their program. Why is that my job? And that goes back to that data triangle. To have translation, we all need to work together, and there's no one who's going to know the results and know the importance of the results better than you who produced them. The last problem that I see is this is a great quote from Mahatma Gandhi, we must become the change we wish to see in the world. If you had told me when I finished my MPH that I would need to be a leader with data for public health to move forward, I would say that wasn't covered in my program. And then when I went off to state agencies, and I've been in several of them, I was always looking for someone else to be the leader. The message here is if we want to create change in public health, we are all leaders, and each of us need to see and take those data roles. Why don't we stop here? What are some of the other problems that you see that you're experiencing in trying to use data effectively? We got someone typing in the background. If you could be on mute, that would be great. Any comments? I'm not hearing anything, so I don't even know if you're on the phone.
Hello, this is Cheryl from Minnesota. Can you hear me?
Hey, Cheryl.
Hi. Well, I work on PRAMs, and this last year CDC, for our new grant cycles, they're requiring us to kind of have like 2 data to action examples, and then each year we need to have two new ones. And so the problem I see is that we work really hard on something like preconception health, and we got a grant and that. Now we have to start on something else. So do you have any suggestions?
Boy, isn't it fun to have widgets? You can create change with a data system simply because someone mandates that you do that. First, to give credit to CDC, the reason they were doing that is because I've been in states for years where they would not even do anything with their PRAMS data. So I think the key gets to be is preconception health is a huge area. So if you're working on preconception health, I would think that you could do a data to action piece, several of them, in preconception health alone. So the first thing is don't think of it as only one thing. Think about, can you do further analysis as you work on your preconception health program, each of which is a data to action, especially if you're working with the program people to figure out what the issues are. The other thing gets to be is I know periodically we create state questions. What I'd like to say is you ought to be working on those not to just figure out which are the best questions, but what are the priority issues that you need to be addressing so that you can then use your PRAMS data to help do the right analyses, to help work with those priorities so that you can use those to lead to better action. Does that help?
Yeah, I know. I mean, these data to actions are important, but it's like, we have this, we have preconception health grants in the state now, but, then we kind of have to drop the ball, and then...
You don't have any other preconception health issues to work on?
Excuse me?
You don't have any other preconception health issues to work on that can be supportive of what you're doing with your grants?
Well, we're working on 4 to 5 issues, but I've already submitted that whole thing as one, I guess. I don't, but now we have to look at other ones.
I guess the key gets to be, I'm not the CDC project officer. I can't tell you what's necessary. The whole idea is they want to make sure that you're using PRAMS and analysis that creates change. It really looked good that you got preconception health grants with your one big piece. I think the question gets to be is not every year you're going to get big grants of money. At least in Florida, that doesn't seem to happen with our current budgets. But there are refinements in policy and program that we need to do, and there are analyses that can frequently help me do that, especially if you say you have 5 areas. I can't believe that you can't necessarily be trying to figure out what those things would that help those grants do better. That's just throwing that out there. So in other words, not every big data to action can be a huge event.
That's true.
And I don't think you should build yourself into that expectation, because I don't think you can have 2 big events a year. In my experience, if I could get a big event every other year, I felt like I was doing highly successful. But I think every year we could contribute to change that made a difference. Does that make sense?
Yeah, that makes perfect sense. Thank you.
Other questions? Problems with data use?
Dr. Sappenfield. This is Chris Hill from Virginia. My question or my issue is that we've been engaging our stakeholders and our partners and providing them with data, and we're started to engaging them and working with them in order for them to understand and adopt the data and weave it into the program. But we're starting to hit the wall where it's sort of becoming data overload, and people are just checking out because we keep giving them data and we keep saying this is the problem, and we keep repeating that this is the issue and telling them that this is the issue, and then they just are sort of checking out. How do you suggest we combat that and try to reinvigorate them and re-engage them?
Interesting question. The key gets to be is what are they engaging in? In other words, what are the priorities? And the way you get new items on the agenda is when you get back to new priorities. So if you've already tried to tell them 20 times and they now heard you and they're reaching the point that they're sort of glazing over because they literally have heard you way too many times, I would say that means the right opportunity is not there, or that you need something new, a new opportunity, a new approach, something different. For me, those creative ideas don't occur all the time, so I'm usually around for a while, so I usually may let something sit and wait for another opportunity, a place where it's different. But the key gets to be is sometimes we think the data should lead the priorities, and if it's data-driven, you would think that sometimes is true. But it really is, in my experience, an ebb and flow. And so, to me, if we're not using the data, then I frequently will go out to figure out, so what is it that you're focusing on? You learn what their priorities are, and then try to move what your data efforts are to enhance them. The way I like to look at it is, with data, I'm not going to move objectives. I'm not going to improve health. The only health that I can improve is by the people who have those resources and what they can do to change. And so frequently when I'm on deaf ears, or there's not enough money and we're really clamping down right now, there's only a few things I could do, then I back off and I say, okay, what are those few things you're doing? Or is there this next new grant we can come up with and compete with? Or is there this other new partnership thing that we can develop to the side? But something needs to be either within their priority areas or something that's exciting enough for them that they're going to embrace it because it brings in new research and opportunities. And then sometimes, this sounds terrible, but I wait till the person in that position changes. And in fact, later in my career, I was smarter and came to those conclusions early. You know, I give people some good tries and good opportunities, and if they don't light on them, then I go look for somebody who is. And when my boss says something about that and we have an ongoing discussion, I said, well, I'm happy to work with them as long as you can get them to change. And they have the same change problem usually that I do. You know, we think sometimes it's just the data, but the same people that you get who can't change with data frequently won't change because of authority or leadership either. So you recognize the problem for what it is, and you move to where you can create the change that needs to happen. Does that help at all?
Yes, it does. Thank you so much.
The challenge gets to be is when you've got a boss who says, you've got to deal with this one issue. I mean, I had a boss, we had fetal infant mortality reviews, and I was leading, coordinating those to make sure they were data-driven, and where there's one community that she really wanted into, and it reached the point that I had to sit in every community review meeting, then I had to coordinate each of the meeting, and then I had to prep the person to lead the meeting, and then when they even found problems within the community, they would deny and not see those as really problems anyway. They couldn't really create any change. And I did this for 2 years, and then I finally went back to her and pleaded for mercy. Please, 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 I'm spending 80% of my fetal mortality review problem in this one location, and I'm having all this success with the 20% of my other time. Are you really sure this is what you want me to do? So in those trap situations, I eventually, I'll stay in the trap for a while, but eventually I go back to the leadership and say, is this really how you want to spend your resources? And eventually they say, you're right. I'm sure you all must be in some of those trap situations.
Oh, yes. How do you learn when to chew off your own leg and get out of the trap?
Say again?
When you learn, or at what point do you learn to chew off your own leg and get out of that trap?
Oh, I understand. And the key gets to be, this is the part that's not in the presentation, the key gets to be is having a relationship with the decision-making process and being nice and not arguing, not complaining. This is all about, we all want success here. This is just trying to get them to listen to the situation and tell them what the problems you're running into. And then the key gets to be is most of the time they're looking for a solution. And if you can't figure out the solution where you're chewing off your own leg, this is where you got to go back and say, well, I'm spending a little bit of time with this other thing. And look at all these results I'm having. So tell me which one you want me to do. And so usually if I give them this other opportunity, they will say, I think it's time. In other words, I'm not leaving them the problem. I'm giving them some choices. I think the key gets to be is when we sort of leave the problem on their doorstep as if they can do something with it.
When you're or the experience I've had is you're helping them to cope with the problem, deal with the problem, and then you're giving them, obviously initially the low-hanging fruit that you're pursuing are easy changes or easier changes to make and to impact. And then you've made those progresses and you've made the positive change occur, and you've reached a precipice where you're no longer seeing any positive change and you've leveled off, and then they're even with additional data and with additional collaboration, there's no meaningful progress made.
So something else needs to change to make change happen. This is when you argue, say, so if we're going to keep doing this, something else needs to make this situation different, and what is it? So let's problem solve. And, I've had to spend those discussions for a while before they would realize that there wasn't. But you're right. There are certain situations that you maximize where you are, and that's it. And hopefully that's not the only source of your funding for your position, because once you really hit that wall, you're really in what I call a maintenance mode, and maintenance is extremely important, and every system needs to have it, but it's not one of my most favorite things to do. Other comments or questions?
Are you there?
Yes.
Okay, I do have a question. I thought I'd type it in, but
well, I haven't seen the typing screen. I guess I could look at that.
Yeah, it's all right. One of the questions that I have is, that comes back, is how to make the data look more visually interesting. Because some of the comments I keep getting is like, oh gosh, not another chart, not another table. And so it's like I have really good, interesting data, and it's good to talk about it, but visually it looks kind of boring. Are there any software programs out there that you use, or, how do you make numbers more dynamic than they already are? I mean,
well, there are data and there are reports, and we can try to talk about some of that, but really what people want is, and nowadays they're overloaded. I mean, they can go to the internet and get numbers and data and statistics. They're looking for information, and information to me is data that's going to make a difference. We've talked about that some during the summer. So the key gets to be is not showing them another graph or chart. The key gets to be is what is the critical question that needs to be answered? And then two, what is the answer? And if I can show that with data, or if I can show where that is, then that will be what makes the difference. Does that make sense?
It makes sense to me, totally, but I'm working with a group that they just, believe it or not, they like a lot of data, but they just visually, when you have all these tables and charts, And they're, you know, I'm working with a really great team now. They're really looking to you know, modify certain processes.
Well, yours is a good question. I don't know the immediate answer because some of it depends on the context of the data and who the audience is and what you're trying to present. But the idea of resources out there on creative ideas, that may be something we can find, and maybe I can talk with Deb and we can look to the outside.
Yeah, because I mean right now, like I said, I'm really excited because the team is really looking at ways to modify the processes that we're going through, because part of the problem was we're getting all of this data, but it wasn't useful because the questions that were being asked previously were not the right ones. So we're getting to that point where everything's changing, but again, it's the presentation of the data that for me is that huge issue.
And part of presentation, again, it really depends on the context and the audience. I know some people who like figures, and then I know others who want just talking points. Don't give me any graphs. But we can see what options are out there and try and get back to you.
Okay, I'm sorry. My name is Rose.
Thank you. Yes, thank you.
All right, thanks.
So let's talk about effective MCH Epi practice. Deb Rosenberg, after her work by Arden in the Evaluation CDC program, CDC gave her a grant to talk about and find out what are the key ingredients to effective MCH Epi practice. And many of you may have been around long enough, but they actually ended up interviewing all 50 states in D.C. and in 2-hour interviews with key stakeholders, and they collected a written survey, and they looked through block grants and data sources and others, and they characterized states that they thought were high capacity, medium capacity, and low capacity. And from that, we've learned a lot of valuable data about sort of what really matters about MCH Epi practice, especially at a state level. This first diagram we gave you sort of lays out what effective practice looks like. First, on the far left, you see there's the population content and the population context and public health context. And then there's agency health structure, then there's the actual MCH effort structure. There's then the actual MCH effort processes, and that leads to an output of some type that leads to an intermediate outcome that hopefully changes health status. And that many of these processes not only lead to outputs, but also actually come back and rebuild and change the structure of our agency and of our own unit. So it's an iterative process in terms of development. To give you some ideas of some of the functions by health structures we're talking about, includes sufficient funding for continuation staff development, includes databases and software. Under MCH Epi effort structure, we're talking about having, a lead epidemiologist, sufficient staff for data, participation in leadership of the agency. In terms of effort, we're talking about providing analytic direction, expertise for data system development, conducts high-level data analyses. In the outputs, we're talking about disseminating reports, generating briefs, communicating and working part of a team, leading to planning and other documents. Hopefully that leads to program change or policy and health status. And the loop might be further data linkage and integration, or submission of grants, or hiring a new staff, or submission of new resources, all of which change that context. And this sort of laying it out seems obvious, but it took us a little bit of time to walk through it, and it was very helpful for us to lay out. So what they did is they went through from that framework and decided what are some of the key components. What really makes a difference? What puts a state up at high capacity versus medium capacity versus low? And these are some of the results that came out there. Organizational position is borderline significant. By that, what we're talking about, is there a recognized unit doing MCH epidemiology? Instead of fragmented and disseminated all over by all the different program areas, is there a unit? The second is there an agenda setting there that takes place by consensus? In other words, who is determining the analyses? Who are asking the questions? Who are helping us figure out what it is that we're trying to accomplish from a data perspective? And the strength of that even goes up if you talk about including external partners. We used to think about being an MCH epidemiologist leader, and that helps some, but really part of also what makes a difference is really how many doctoral trained people, how many senior people we have who know what to do with the data and lead. It doesn't mean that I have not seen effective master's leaders, but if that person turns over, the next master's may not have all those skills. So that makes a difference. And then if it's a learning environment that's actually doing something, there are CDC assignees or interns or fellows or someone who's helping to generate those products. And then the last piece is there routine data sharing and data integration? How available are data sets and pieces where you can actually do things so that you can actually do analyses? And so these are some of the key components that were highlighted that I thought would be helpful as you think about effective data practice, because these are key issues. They also came up with sort of final recommendations for states. So this is somewhere between the interviews and the analytic work they've done, where they came up with their best recommendations. One, establishing a named unit is helpful. Ensuring its leadership has organizational recognition and authority. In other words, you're not just a scientist, but you actually have some authority and some recognition for the role that you play. That you acknowledge its broad scope and collaborative approach. It's not a really narrow defined piece. That you try to increase your analytic capacity by the capability to hire like doctoral degrees. That you actually need to have a critical mass, so that if you're working on building that, having additional epidemiologists are helpful. That you really do pursue these opportunities to bring assignees and fellows and interns, and they're offered pretty much for anyone, and they can be great ways to prove to projects. That you provide that you really need to have time and funding for staff for training. That within the epi capacity perspective, the subject matter, the analytic approaches, the tools are changing rapidly, and that if you don't have that training, that soon that you'll be limited by what you know. Ensure direct access to a variety of data sets, routinely linked beyond birth and death certificates. Disseminate work using multiple approaches and venues. Jointly translate findings into information and action, and then support external partners turning data into information. So some of these are the nuggets that I shared with you. Some of them talk about capacity. Some of them talk about what federal agencies can do. But the other thing to think about is if you're truly trying to do data translation, part of what you need to do is capacity, and developing your capacity to be able to do that work is important, and they're interconnected. There's actually a published article on this in the MCH Journal if you're interested in more reading about it. So some of the keys. Well, I guess we need to be on mute when we're flushing the toilet. Clearly the keys. Remember that it takes three. Don't think of a project where you don't think knowledge-based, social strategy, and political will. Consequential. You're really trying to focus on it, making a difference, and clear ahead of time what that is, and such. So now I want to talk to an example. The example I'm going to talk about is one that happened here in Florida. When I came and started in 2005, Florida has had a Healthy Start program. We have our own state program. I sent you a 2-page description of what that program looks like. It's a pregnancy support program started in 1991. It identifies women who are at risk. It provides coordination and support services for those women at risk. It does it through 33 local coalitions that are spread out across the state. Some serve single counties, some serve multiple counties. Most of the coalitions are 501c3s. They're free, standalone people who don't provide service but contract for services. The idea was to have leverage of local resources. They may use health department, but they may or may not. They provided a whole series of services. They wanted to just demonstrate when I got on board that they were an evidence-based program. So one of the charges when I got there was we needed to evaluate their program to show how they're effective and the difference that they're making. So they've now been in existence since 1991. It's now 2005. They had tried to do this evaluation with the university. They didn't have money, so they did an RFP for a university to line up with them to go after grants, but then the university couldn't get the grants because it was estimated by one university cost almost $1 million or more to do the evaluation, and they didn't have that much money. However, the program didn't mind taking credit for the decrease in infant mortality from 1991 to 2005. And in fact, they were talking about how they were highly successful at decreasing the infant mortality rate. And you can see the graph here. And now I can show you the graph from this perspective. And I will tell you that the rate in infant mortality in Florida from 1995 to 2005 was flat. That if I do the joint point regression line through this, you'll see that there is no real change. But they still didn't mind keep talking about how they were decreasing infant mortality. So the charge got to me. I got a program who has over $40 million of state dollars. They're our largest maternal and child health program using state dollars. They've been able to protect those dollars from cuts by the legislature because they're politically connected locally. In fact, they were able to politically get themselves written into Medicaid reform as one of the few agencies, even though the Department of Health couldn't. Even though the Department of Health tried to cut their budgets, they had the legislature restore it. So they're very politically powerful. And their whole focus was on being evidence-based. So at this point in time, if you were charged with evaluating this program, what would you think? What would you be worried about? What would you do? The line is open.
I think we need more data.
You think we need data? There's certainly nothing here to tell you we can evaluate the program here. Is there anything from the context that you would want to know before you went for the data?
Hi, Bill. This is Debbie in Nebraska. I'm
Hey,
not exactly
Debbie.
sure where you're headed.
Okay. What do we need? We just talked about what it takes to evaluate a situation. So what do we need to do to use data to be effective? What are we looking for to have?
Well, the defensive part of me would say, well, let's see if we could project what it would look like if our program wasn't there. So there's certainly an aspect of that that's going to answer your question.
You're going into methodology and evaluation. I understand. I'm going to ask questions like, who are my stakeholders? Are my stakeholders ready for evaluation?
So what if the answer to that is probably not, as you discussed before, that people don't want to know?
Well, the key gets to be is again, they wanted to know, but they wanted to know only good data.
Right.
They only wanted to know the right answer. So the key that I needed to do was help them shape through what their context was and what they should do differently. So when I was there about infant mortality and I was talking about how it was flat for the first time, they said, well, Bill, we want to come talk to us to say, what can Healthy Start do to further reduce infant mortality? It's been flat for so many years, and we're charged with doing that. What do we need to do? So what I did is I did a talk on infant mortality, and I showed that the engine that's been driving infant mortality dropping is birth weight-specific mortality rate. And the reason that it had gone flat is that our birth weight-specific mortality rate was no longer improving. And then I went through the literature and showed how that most of the improvement in birth weight-specific mortality actually relates to receipt of perinatal care and specialized perinatal care through a risk referral system. And that those were the primary factors. And so that if we were going to, that birth weight and preterm birth has not changed. And so the first thing is I focused in on what were the drivers decreasing the infant mortality that they should be anticipating. The second thing I did is I did a little quick search for the effectiveness of pregnancy support programs. And I went off to Cochrane and I found the following quote. This is their analysis of support during pregnancy for women at increased risk of low birth weight babies. Pregnant women need the support of caring family members, friends, and health professionals, while programs which offer additional support during pregnancy are unlikely to be clear, unlikely to prevent the pregnancy from resulting in low birth weight or preterm birth, they may be able to reduce the likelihood of cesarean birth. Needless to say, when I presented this at the coalition meeting with all 32 coalitions at the time present, that created a little bit of a stir. Because first thing I said was our mortality rates were dropping predominantly because of birth-specific mortality rates, and that's been predominantly associated with perinatal care. It doesn't mean Healthy Start wouldn't be, but there's not a lot of evidence to support that, and I didn't find any articles. And then I came back with this analysis saying that. And, of course, the immediate discussion was, Bill is saying Healthy Start doesn't work. And they took them a while to think about it, and then they said, well, no, that's not what Bill said. In fact, I came back and said, all this summarizes what the literature has. Healthy Start's not been evaluated. There's nothing published in there. There's nothing clearly what Healthy Start is. These models aren't exactly the same. So there may be something that works, but at least right now in the literature, there's not an evidence-based program that affects these outcomes. And so after much discussion and much heat, the first thing that we did was the department joined the coalitions, and we formed a research work group. And that research work group was charged to have two aspects. One, to look to make sure that the program was bringing in the latest research that could make a difference so that we were moving more towards the cutting edge. But then they also put together an evaluation subgroup. And that evaluation subgroup was charged with reviewing any past evaluations that may have been done, and there had been some, but they were very weak, to review what some of the key literature has been showing about what the right evaluations may be or what might be working, and then three, to push us towards evaluation. What did that have us do? The first thing it had us do is we changed the question. No longer was I being asked to show that Healthy Start worked. I was now being asked and formed in a group, in a partnership with stakeholders to ask, does Healthy Start work? So we changed the context. We formed the stakeholders. We got policy people together, data people together, and program people together, and we now decided to pay attention. We did go through all the old reviews to see how well those evaluations were, and most of them were weak. Most of them did demonstrate that Healthy Start worked. So we started to move for new opportunities to go ahead and evaluate. But the key you got to see here, guys, is what end result am I looking for right now? The end result that I'm trying to frame in front of this group and did frame in this front of group is I want to improve Healthy Start. I want us to assess what's working, what's not working, so that we can make this an effective program. In that, we need to know if what we're doing currently is working or not working so that we can shift from what it needs to be. We need to do this in a political context because we have all these community groups who are politically as important as the department itself, even though they're just a contractor. So let's walk through some of what we evaluated. The first thing we were lucky and able to do is we got a Medicaid waiver through Healthy Start, and with the waiver we were required to show that the program worked. And some colleagues of ours at the University of Florida were contracted to do the evaluation. In fact, they did it twice. Once was the first round and then the more elaborate round. And they did a very, very nice job because the key gets to be is trying to evaluate. And they did it with the money that we had available. Obviously, we didn't go out and collect new data. We tried to use the administrative data sets that we had available. We have linked data sets that took birth certificate data to Healthy Start data to Medicaid encounter and claims data so that we could look at who were the Medicaid people on and what were the impact on outcomes and what were the impacts on medical costs. So what we did, the first analysis showed no effect, or not much effect. It was not completely robust. It looked at all the healthy starts, yes and no. It didn't take community context into account. It didn't control for all the potential risk factors. So the first evaluation that they did was general, but it was somewhat discounted. So then we went back and said, okay, this time we're going to compare high benchmark coalitions to low benchmark. In other words, who were the ones really working in the coalitions, reaching the largest group of women with the most amount of services, and who were not. And then we also compared them to those women in those groups who didn't get care. So in other words, we looked at it between the high and low, and then in the high places we looked to see if there was a difference between high and and didn't get services, and the low counties and didn't get services. So we had lots of comparisons here. I talked about the merged files. We looked at trying to define service. Did they get initial contact? Did they get initial assessment? They had to get care coordination services to count because we wanted to give them the full package. So if they didn't get care coordination, we dropped them out. And then supplemental services. So we have sort of all women. We look at those who got care coordination and those who didn't get any services, and we started to compare the others. Now, in our services, women had to get a score of 4 or more to be the high-risk women, so we actually limited to those who got 4 or more. Even if they got Healthy Start service below that, they were eliminated. Okay? We were trying to figure out how do we select the high and low counties. And so these were the factors that we ultimately selected. We actually chose 6 or 8 different mechanisms. And between those 6 or 8 different mechanisms, we generally ended up with the same counties plus or minus 2 counties. So even though the criteria we used could have varied, varying the criteria really didn't change the counties that we included. So again, here are the 3 comparisons. We have high benchmark coalitions to low, benchmark coalitions to got services to those high benchmarks who didn't get services and such. We also took community variables into effect. We have our pre-waiver time period, a transition time period, an early post-waiver, and then a late post-waiver because this evaluation, the second one was long enough in that we could actually have 2 post-periods to see what impacts were taking place. We're just going to continue on. To get a sense of what these graphs look like, if something really worked, we were to be trying to find a difference. So we would expect that Healthy Start would have already had a difference of some. And then with over time, with more intensive services that Medicaid was bringing on board with the waiver, we should have had more effect. Because again, Healthy Start's been going since '91. We can't go to a period of time where there was no Healthy Start. But we could go pre-waiver, which had less money, transition period, substantially more money. It was supposed to provide more women and more contact, and then see what happened. I give you this sample graph here because the following graphs I'm going to show you are not going to show those patterns. So I wanted you to see what a theoretical pattern should have looked like. The first one we had was the percent of preterm births. Again, the high Healthy Start coalitions to low benchmark coalitions are in red. The high to no are in yellow. And the low high to no is in green. And as you can see, there is no clear pattern here, and only the one with the stars are statistically significant. So we move to preterm births. We'll go to low birth weight births, and again, none of these were significant. And it gives you the impression low birth weight going in the wrong direction. Then we have small for gestational age, and it's significant in the wrong position, but it's in the transition period. We then looked at timely prenatal care and really got confused when we saw these results. I'm not going to go through all of these. You have the slides. You can see what we looked at. But there really were not a lot of positive messages that came through this. We talked about all the typical statistical limitations that I mentioned that program people don't like. Then we talked about some of the strengths that these services had. We examined outcomes and medical expenditures. We really looked at the strongest programs of care coordination with the highest risk women. We looked at independently ascertained outcomes, so the data collection was not biased by the program. We had multiple comparisons. We adjusted for confounders. We even adjusted for differences at the county level and did not see a concern pattern. And our conclusions were some low-risk women are receiving care coordination while some are high-risk women are not. There's high variability between coalition sites and the provision of care coordination, and the variability in program implementation may have contributed to inability to detect differences. Outcomes. Healthy Start did not show a consistent pattern of improved preterm, low birth weight, or small for gestational age birth. Healthy Start did not show a consistent pattern of improved timely prenatal care or postpartum services. Expenditures. Healthy Start demonstrated some reduced expenditures and delivery costs, and that was consistent, but it was an opposite direction of increased expenditures in both the prenatal period and infancy that were more than the delivery costs were saved. And so our conclusion was Healthy Start does not appear to be impacting birth outcomes, healthcare costs, and this is consistent with most of the literature for pregnancy support services. I didn't like that last call. I'm not going to spend a lot of time on the methods piece. We can come back to those, but I want to go on to the next piece. So the next piece was, well, we keep saying that maybe Healthy Start, it's a lot to expect infant mortality, prematurity, and low birth weight. Those are socially and medically complex outcomes, and assume that one simple program has a effect across all of that out of the context of all those other factors may be unreasonable. And Medicaid costs, well, we can't save all the costs because Medicaid doesn't pay for all of health. It just pays for health care. So maybe what we ought to be doing is looking at other, what we call more proximal outcomes that should be occurring that should be then affecting infant mortality, preterm births, and seeing if Healthy Start's having effect. So this is where we came back and did our study within the health department. And what we did was, most of the time people looked at Healthy Start screen, Healthy Start services, and then looked at outcome, as if something happened between services and these distal outcome. And they do that by the linked files that I show below, Medicaid, WIC, live birth, Healthy Start. What we did is we added an in-between. We added prams. In other words, we tried to hypothesize that if Healthy Start was working, we were going to have more health education delivered. We were going to help women maybe quit smoking, maybe infants to be in better sleep positions, maybe more breastfeeding. Maybe we did better with contraception. Is Healthy Start really changing some of those health, knowledge, education, behavior things that we thought those support services were providing? So our question was, is there association between Healthy Start prenatal services and maternal and infant health behaviors? And with PRAMs, we identified sort of 5 under the perinatal period and 5 in the postpartum. Adequate number of prenatal visits. Healthy Start won't get you in early, but it should get you more visits. Did it give you more prenatal counseling? Did it give you more WIC participation? Did it give you more gestational weight gain? Better or more appropriate with gestational weight gain? Did it prevent NICU admissions? And then on the post-period side, did we get more women on postpartum contraceptive? Did we get more people seen by a health provider in the first week after delivery? Was there more breastfeeding, and did they do it for a longer time period? Did we get babies in a better sleep position or location? Did we have some effect on the environment and less passive smoking? Anything that we thought could be improving through our education, which the program claimed that it was doing, could be affecting outcomes. Again, we've merged this data set that I showed previously, and now we've merged it to PRAMs. And because this is a statewide program, with enough years, we had enough data to look at that. We actually combined 6 years' worth of data to be able to do this analysis. And then we did the same idea of they had to have care coordination to be considered in this analysis. And then what we did was we compared intervention groups. Now, we didn't look at the other Healthy Start services. We dropped that out presenting today. We actually did analyze it, but I'm not going to share those results. We mainly said, did you have coordination or did you not? And then to be robust, we actually compared them to two groups of women. In Healthy Start, we screened 70% of women in the state. But not all women get screened. So what we did is we looked at those who got screened and didn't get Healthy Start services, so we can risk adjust there. And then we looked at those women who were not screened but did not get services, and we used PRAMs as our risk screen so that we could have comparable groups. So now we have the group who are the non-participants who could have a selection bias because they didn't participate, to women who were not screened at all, didn't know it existed, and looked at that group who did not get services in comparison. So we have two comparison models there. Again, we did this normal statistical procedures. I'm going to give you some of the summary results. We actually found that we increased adequate visits. We had an odds ratio of about 1.1. That means we had a 10% improvement assuming that they got slightly more adequate visits. We averaged on average one more prenatal education topic being covered by the program than not. And WIC participation increased a total of 10%. On the neutral side, we had no difference in weight gain, inadequate or excessive, and no difference in NICU admissions. We had a small increase in breastfeeding initiation and duration, again, about the 10% range. We had no difference in postpartum contraception, no difference in seeing a provider in the first week, no difference in back sleep, no difference in bed sharing, and no difference in passive smoking. We went through all the traditional limitations, and we went through all the strengths of what we covered. In conclusion, Healthy Start improves some pregnant women and infants' health outcomes, small level of effect. Healthy Start may benefit from program enhancements and increasing intensity. Further evaluation studies are needed. The bottom line is most of these messages were negative. Now let me give you the scenario that I was given to present these findings. I was going to be invited back to the Healthy Start coalitions to tell them all these results. And as you can imagine, I was not going to look forward to that meeting because have you ever been presenting in front of a group of about 80 or 90 people highly negative results for something that they've been working on, some of them since the beginning of Healthy Start? Not a positive piece. So the question got to be, let's look at the results ahead of time. My intent is to improve Healthy Start. So somehow I need to figure out how to do this. So process is as important as content. So we have an advisory group. So we started to share some of these results with the advisory group ahead of time. And we started to, didn't always show the definitive results, but we kept talking about how the messages were negative. We did that for about 9 months before my presentation because it took that long to finally get to the conclusion report. And in fact, I don't know about your experience, but when I do a program evaluation, even before I start this one, the first thing I tell people is you need to be prepared. If you haven't looked at this, your results actually may be negative. Because most things that haven't been looked at, haven't had close scrutiny, usually end up being negative. And so the word got out that they were negative. So then, as it got negative, we approached Healthy Start leadership and said, you know, guys, it would be good if a small group of us got together and talked about what to do if the final results come out negative. And we got together and we developed a planning process for how we would revise and enhance Healthy Start in a collaborative fashion so that we would now become and move to a more research-informed and evidence-based model. In fact, we had a pre-meeting of a larger group to talk about what that process needed to be like even before the results were shared. so that when I got the chance to present these results to them, we had a panel discussion. We didn't take questions. We had a panel discussion, and I put the advisor group, especially the Healthy Start members, up front to explain the results. And I also was there, but they were the ones officially sitting on the panel. So that our discussion was not only about questions about the study and the methodology and what it meant and whether it was accurate or not, we had a discussion about, so what do we need to do next? And what does that need to look like? And how do we create that change? I must tell you, when I finished the presentation of the second analysis and showed, one, Healthy Start not only didn't work in overall, but it didn't even work in our best counties. And I said, and it even didn't work on some of the behaviors that you thought you were specifically targeting. Even the group who actually sort of knew what the results were going to be when they came out were speechless because they'd spent years doing this. But the time got to be is the discussion went from the study to what it is we need to do next. Now, let's be clear, it wasn't pretty what we did next because they actually had to have a meeting of the family during that meeting where a third of the Healthy Start coalitions were still saying, we shouldn't do anything differently. This is just fine. We're already funded to do this. To the other two-thirds saying, we will not continue to be funded if we don't move to something that's more evidence-based. So I'm going to move towards having questions at this point, but what I guess I'm trying to do is give you a scenario where all those things that I talked about needed to happen. We needed a team. We needed to focus on the right question. We needed to see where the results were going ahead of time and what we were trying to accomplish. We needed to orient people to what those processes were. We needed to engage them not just at the end, but what were the right questions, how is the analysis going, what are the results, what are the interpretation, and then, more importantly, what are the recommendations of what we need to do with this? So when we talk about recommendations, it wasn't me, an epidemiologist, telling them what the next steps were, and it wasn't even just us as a program because it affected the field so much. It was all of us talking about what needed to happen next. Now, going back to this, how many people do you think actually read the article or results? I mean, the first one is actually published in the MCH Journal. None of them did. But I promise you, most of them knew what the results were and knew what needed to happen. Questions? Just so that you know, we're now about two-thirds to three-quarter way through our redefinition of Healthy Start and trying to make it evidence-based, which actually has not been easy because the literature hasn't changed a lot, but we're struggling with those pieces. Questions, comments?
Hi, Bill. This is Kristen, the PRAMS Epi coordinator in Michigan.
Yes.
I have a question about the power of the...
You're asking about what the power was? The sample size of our intervention group is we had almost 7,000 women who were in Healthy Start.
Okay, and so was it, were you
able to... So the power is quite high with PRAMS.
Oh, I'm sorry. Were you able to look at a dose-response relationship according to the different programs that had different levels or different reach of services?
Well, you've got to be careful with a dose response. This service is targeted based off of risk. So women who got more services could also be those more at risk. And so it's not a simple dose analysis. We did not feel like we had the medical factors and other factors are not enough to capture all of the social risks that our service people were using to provide those services. So we did play around with that, but what we thought was a better model was to look at the high-intensity counties versus the low, so that we got a better sort of what we call a dose response, if that makes sense,
right,
and not caught up into the risk bias.
Okay, what about, Bill, this is Patty. The follow-up to Kristen's question is I noticed that you're using WIC and WIC enrollment, and, at least in Michigan, would you also expect that might be modifying some of your results?
WIC was an outcome, so it was not an adjusted.
Okay, but also we know that WIC will modify the response to breastfeeding and it can affect initiation and duration.
We did look at that, too, to see if it did or didn't, and that was not the factor.
Wasn't a factor?
No.
And then also, a lot of these women, at least we're doing a Healthy Start, or we're trying to get a Healthy Start evaluation done here in Michigan. And one of the issues that we have is women are enrolled in multiple programs, like MIHP, which is the Maternal Infant Health Program, Healthy Start. They may have, so they may be enrolled in a number of home visiting programs. Is that what you're referring to when you're talking about, higher risk women are getting more services? Because that may or may not.
Well, theoretically, our Healthy Start programs are coordinating their efforts with these other communities. And so, in fact, some of the high-intensity counties actually did have federal Healthy Start, but a good portion of our state is not covered by federal Healthy Start. And so those could be making, but again, most of those who are in Healthy Start, in federal Healthy Start, are counted as part of Healthy Start.
Okay.
So it's really hard to separate them out. And the other bias, I mentioned the risk bias with more care. The other problem is the participation bias.
Right.
Sometimes better women will participate more. So we try to stay out of both the risk and the participating bias. And in terms of programs, there was such overlap between our federal Healthy Start and our Healthy Start, one, we couldn't tease them apart. So in fact, what we were doing is giving credit to Healthy Start for the federal Healthy Start.
Okay.
Does that make sense?
Sure.
Thank you.
Other questions? The data pieces are interesting. We spent a lot of time. I mean, dose response is really a cool one. And if you have a program that's designed that lets you really look at that well, I will be impressed. But the participation bias is really strong, and so is the risk bias. The other problem, too, is you need to know exactly when all the services are provided, because if they're provided later in pregnancy, they have better outcomes because they're included in program services later. So you have a lot of different biases in there you've got to be very careful with. And we did not think we could control those. The key gets to be here is, maybe this looks simple to you. This was far from simple, very complex, and the people were there. But the principles that I'm talking about that you need to think about were extremely important in this evaluation, and had we not done those at any one point in time, we could have had a lot of trouble. But because we did it in that sort of an organized fashion, we actually were able to create the change now that we're trying to have.
Bill?
Yes.
This is Debbie again in Nebraska. I don't think anybody on the call thinks that this was extreme. Sounds simple. And I'm quite impressed. Do you have anything written or published on the steps of this, or the methodology, or the original, not necessarily the outcomes?
No, I have not written this process up yet. And part of it has been, since we're still in the middle of the politics of it, maybe this would be worth writing up at some point, but probably not quite yet.
Yeah, the outcomes, of course, your results are interesting, but the whole process is, for us is probably more valuable.
Yeah, well, that's why I wanted to share this and try to bring home that this could be done. What I'm advocating is on a simple project, but on a larger project, it can be quite powerful. And again, if we hadn't had stakeholders engaged, if we hadn't had all these other pieces, a lot of things could have happened. And the worst thing is we could have even potentially lost all the money for Healthy Start over the process. So again, effective data reutilization involves all these pieces, but the key gets to be is Bill Fahy says, and now Tom Frieden, it's that consequential, that's intervention epidemiology. It's thinking down the line where you're trying to go. It's remembering where you plug in at the different key data steps. It's about pulling in the partners to ask the right questions. It looks like when you do presentations like I did, it looks like we did the right question and the question was obvious. I will tell you that it always post hoc looks like you answered the right question. And we certainly only present nationally at regional meetings those that are ones that are that direction. But ahead of time, it really is important that people ask for the information, they ask for it in the right framework, and that they actually want to see the data when you give it to them. And they actually know what they're supposed to do with it when they get the data. Now, they may always not do what they should do, but those pieces need to be worked out. And the challenge as an epidemiologist is it makes you and I know a little bit more about planning, a little bit more about program. But guess what? If you're like me, you're expecting that program person to also know a little bit about data, a little bit about analysis, a little bit about limitations. So it's a two-way street that we've got to close that gap. If we don't both go in each other's direction, we'll never have effective translation. I didn't go to my question and answer to see if we got it. I don't think we have any more. Are there any other questions, comments? Well, I don't know if this worked on a distance format or not. I certainly enjoyed you guys very much in a person format. I hope you've enjoyed today. Oh, I may have a question.
That was probably mine from earlier.
Okay. No, I got yours too, but it looks like something else. But all right. Well, with that, Kristen, I'm going to turn it over for you for a wrap-up.
Okay, thanks a lot, Bill. I think those practical examples really help us all to think about how we, translate. And you even, did some evaluation design for us, so that was nice. So I think with that, we're going to wrap up. I just want to remind you, in case you weren't on the call in the beginning, that the session for next week on September 20th will be canceled, but we'll be meeting again on September 27th at the same time, 3 o'clock Eastern. And you'll be getting more information and slides for that soon from Julia. So thank you all for attending, and have a great rest of your week. Thanks, Bill.
Thanks, Bill.
Thank you.
Thanks. Great session.